Hello, everyone. I am Dr. Eric Thuler. I am an ENT and sleep surgeon in São Paulo, Brazil. I was invited by Dr. Mihoras to talk about transoral robotic surgery, the present and the future. And I will first introduce myself. I am an ENT in São Paulo, Brazil. I did my training, my fellowship in sleep surgery, surgical treatment for sleep apnea in Italy 10 years ago, 2012. And I did my PhD studying how to improve patient selection for OSA treatment. And I am now a postdoctoral researcher at the University of Pennsylvania and faculty at Nicholson Center, part of the sleep surgery and TORS courses here. And first of all, thanks for the invitation. I could spend hours talking about that. It's my research field. I will keep it straight, and I know that most of the audience are not ENT, they are general surgeons, and I will try to give you some insights how we can use the Da Vinci platform in robotic surgery for these procedures. Especially, I would like to give three main goals. I need to mention why multi-level surgery, why we have procedures that address the trunk base and more than one level of obstruction in obstructive sleep apnea, why I use the TORS, and what is the future in my mind. And initially, it's important to mention that the room that surgery has in OSA treatment is because of CPAP. Although it is the gold standard treatment is effective, but the effectiveness is not so good once the patients, they are not able to use 50% of the patients, they do not adhere to the treatment. And so the effectiveness is compromised by that. On the other hand, we have in surgery, we don't depend on adherence. So the patients don't need to use the machine day by day, night after night, and so the data suggests that we can improve cardiovascular endpoints. And the point is, we need for surgery, the surgery has outcomes that depend on the proper indication. It means that we need to understand the mechanism, the anatomical mechanism of the obstruction to have a better results. And so this is my research field. And I've been studying specifically what this paper mentioned, that when we look at patients, this is a paper using cine MRI, it's a dynamic MRI during sleep, natural sleep, and they could demonstrate that 77% of the patients, they had a pharyngeal collapse that was driven by the tongue. So we call that a tongue-driven collapse. And another way to evaluate these patients is to reproduce natural sleep using a drug-induced sleep. And there is studies showing that we can use a proper protocol of sedation to do that. And when we do that, when you use this type of protocol, we can see similar numbers. 70-80% in this review of the patients, they had multi-level collapse in more than one level of obstruction. And this multi-level collapse is also a reason for the worst outcomes of the one-site procedure like UP3. So when we access these patients using drug-induced sleep endoscopy before the procedure, and we correlate the outcomes, these patients with multi-level collapse, they don't do well using pharyngoplasty. Also, there is data showing that these patients that they do not adhere to CPAP, 12% of these patients, it occurs because the positive pressure induced the collapse of the epiglottis, and an epiglotoplasty, a partial resection of the epiglottis, is the most effective treatment. Also, there is data showing that if we have patients with multi-level collapse, instead of doing just a procedure directed to one side of obstruction. We propose a multi-level procedure, including the tongue base resection. The results are favorable. We increase our success rate. And then why I decided to go after transoral robotic surgery. As I mentioned, I was studying pulmonary collapse, and I realized that I need to do something to treat the hyperpharyngeal area. And I stumbled with the work and the research of this professor from Italy, from University of Bologna in Italy, Dr. Claudio Vicini. He described a procedure to treat the tongue base and the hyperpharyngeal area using the Da Vinci platform. He first described the anatomy, describing a way to work in a safer area. It's called safe trapezoid, in between the lingual arteries, and we can reach until the hyoid bone, avoiding damage to any major artery or nerve. So showing that it was feasible to work transorally for a benign disease, avoiding major damages. Second, he described a step-by-step procedure starting from midline and reaching the limits we have on each side. So we have 3.8 centimeters of safe area, and in a way that how we could remove the whole hypertrophied tissue in a stepwise way without losing the anatomical perspective. And also describe ways to better expose this area. One of them is the head position. So instead of hyperextending the head and which reduce the distance between the odontoid process of C1 and the tongue base, we move the head to this sniff position, and we increase the room behind the tongue. And also he described that instead of using traditional thinner and longer blades, we should use wider and shorter blades, which allows to a better exposure of the tongue base area. And another interesting and important point they described is that instead of moving the tongue all the time back and forth the way we do in our traditional procedures, if we they measure that anatomy using a steady position. So if we reproduce this steady position, we position and we stabilize everything, we keep everything fixed, we know that we have these anatomical landmarks in mind, and this also helps to avoid complications and major damage to important structures. Another point that the procedure was really well and convinced me to follow and to learn the way they standardized all the OR staff and the OR equipments. So the tip is that if we gather the OR team and we establish the right position for each part of the robot, and we can, usually I do that in advance when I start a program in a hospital, we dress rehearsal where it is the patient cart, the surgeon console, the video tower, the length of the bed, the position of the bed, and the surgical table. And this exposition and docking that some of you may heard that takes too much time takes no more than 15 minutes, and we can and we developed after case series good exposition, a good positioning of the arms in a way that you have a good exposition of the oral cavity and the tongue base. And this is really what captured my attention. The view and the quality of image we have, the depth of the image we have, I can never share with you in a presentation like that, because only what he told me, and I usually say to those who want to learn about the procedure, that you need to visit us in person to see how clear and how different it is to work in the anatomy, the anatomical details, the anatomical structures when you look at the surgeon console. And another awesome resource is how we can use the instruments moving around almost 270 degrees in a very small area without moving our arms, without any need to have major movements, and which allows better dissection of the whole structures that we need to work. And for this procedure, the idea is that we set up everything. We expose using a 30-degree endoscope facing up. We can look at the tongue base and remove first one side, starting midline, first one side of the lingual tonsils. We can also remove some of the muscle if necessary, and then the other side. And the idea, if you did a proper exposition, we have the hypertrophied tissue blocking your supraglottic area. And at the end, you will see that after removing the tissue, we have a clear view of the supraglottic area. So we can see that the supraglottic and the glottis is free from any hypertrophied tissue. The idea is that during the procedure, we standardize it to measure how much tissue we remove. And assuming that we did a proper patient selection, the results are better if we were able to remove more than 7 cc's. And usually we measured more than 10 cc's. And also later on, they published data showing that instead of using a UP3, a uvulopalatopharyngoplasty associated with this transoral robotic surgery procedure, we use expansion pharyngoplasty, a procedure that does like a lifting the palatopharyngeal muscles to open the lateral pharyngeal walls. The results were even better. And so we also add this procedure, the expansion pharyngoplasty, to the tongue base resection, starting removing the tonsils, the palatine tonsils. And after removing the tonsils, we can use the same instruments. Usually I have one Maryland bipolar to grasp the tissue and one monopolar spatula to dissect and to cut. Both instruments, they have energy, so I can cut using the monopolar and cauterize using the bipolar. I dissect the palatopharyngeal muscle, I cut the palatopharyngeal muscles, and we use this muscle to lift and to open the lateral pharyngeal walls, and moving anteriorly the soft palate without resecting any tissue, which reduces the risks of velopharyngeal insufficiency and other stenosis and other major complications. And then we move, after performing the expansion pharyngoplasty, we move to the tongue base, and keeping the same idea that we will first start midline, dissect, and detect. I like we can view clearly the limits between the lingual tonsils and the lingual muscles, and we can dissect and remove the whole tissue. Another advantage when we dissect step by step, the way I'm showing you here, that removing the epiglottic mucosa, the anterior, the mucosa that relies on, that stays on the anterior face of the epiglottis, we, after the healing process, we also help to stabilize the epiglottis. And when we have primary collapse of the epiglottis during DICE, we can also do the epiglottoplasty, removing the superior third of the epiglottis to reduce the excess of cartilage that it is collapsing the supraglottic area. We have data. So the past 10 years, many different surgeons in different centers, they have been performing this procedure. On average, the success rate is around 70% in 1693 patients. We also have data showing that compared to other procedures, one of the theoretical advantages that I already addressed in this presentation is the surgical time, the time you get to put everything into place, that with rehearsal and training is not an issue. We don't take more than 20 minutes to do all the exposition. But most important to highlight in this paper is that we have data showing that we have less bleeding, less complications using the robot. Still, there is an issue, a discussion all over the world about selection. This paper shows that DICE was not able to improve patient selection, especially the way we used to select patients for this procedure. We have a different criteria for patient selection, and we select patients. We see the tongue-based collapse in two different ways. One, those with hypertrophy, and those with lack of muscular activity, lack of muscular support. And we use during DICE a maneuver, a shin lift maneuver, to identify that difference. In our results seems to be, it's a small case series, but seems to be better than average. And this paper could achieve 89% of good results. And there is a book written by Dr. Vicini and many other of his fellows to describing out the procedure, everything I just mentioned. And what I am trying to do now is to bring a more objective way to improve patient selection for this and other procedures addressing the tongue obstruction, tongue base. Not only we are using facial measures. So we published this paper showing that the intermolar distance, the facial measures can predict the tongue-based collapse that is not caused by tissue hypertrophy. The PEM group also, Dr. Didem group, they also showed that the pharyngeal pressure, the pressure needs to open the pharynx, also can help to predict. And so we are doing a more fancy way to measure pressure and flow to predict the success of these procedures. And finally, what's the future? How I see the future? And I can tell you, I'm sharing my thoughts. It's a exercise of foreseeing the future. The same way we saw on TV how the screens, the definition, and the streaming process involved, and now the broadcasting industry. The same way to cell phones, the evolution of the screens, and how the way we use the cell phones today more for message and testing and video interactions than for calling itself. I see the same pattern going on in surgery. So in my field, we started from indirect light sources to direct light sources to endoscopic view, and we have already systems that they are completely available here in US to offer 4 different arms in 2.5 centimeters. All the arms, they are flexible, and so it's not difficult to imagine that the technology is evolving, and we will have the prices as the technology evolves, they become more affordable, and we will be able to perform even better procedures, keeping in mind that this system has a whole software behind that allows to develop a lot of algorithms to improve performance, to improve training. The courses we have at Nico Center uses a lot of this data on how to improve performance and to develop in an early surgeon the skills to become an expert, to increase and speed up the process that you need to be excellent in what you do, the same concept you use for sports and weekend training, develop exercise and simulations that offer a speed up process for developing this kind of expertise. And there are other platforms that they will come into place in a few years, from Medtronic, from Johnson. There is another one called Med Robotics, and at least more in the near future, more 4 or 5 different platforms. And in my mind, this is for me the take-home message. TORS is an effective tool for pharyngeal surgery at all. We could discuss cancer, resections, and other different procedures. And also, in my mind, it will replace the endoscopic surgery. So the future of endoscopic surgery comes into platforms that they are intelligent and they have a software behind that we can control more sophisticated instruments. So I hope you enjoy it, that I could give a broad overview of what I do, and I am open to questions and to reach me for those who want to know more about it. Thank you very much. Enjoy. Be safe.